Yeah, thanks. That's wonderful. Good morning. Morning to everyone in the room, and hopefully those on Zoom can hear us. We are very excited for Grand Rounds today. For those who might be on spring break, we hope they're having a great time, and just an endorsement to take vacation. We really encourage vacations. I know some are even back from vacation, which is good. So today for announcements, the next Grand Rounds is Audrey Kellerman and Lori Kinney, two of our GREC fellows. So we're looking forward to that. The next Journal Club is I'm going to have to be fact checked on this. Yes, April 9th, Jean Otero Medina and Madison Turner. So happening on Zoom. This Saturday, Welcome Spring with an open house, actually hosted at my house. Would love for anyone who wants to stop by and come, just please, you and your people are welcome. Bring food and we'll have a nice time just connecting informally. So without further ado, our speaker introduction, Dr. Mackenzie Garcia is one of our fellows. She is originally from Colorado and earned her MD here at the School of Medicine and her MPH at the Colorado School of Public Health. She then moved to Atlanta, Georgia, where she was in the primary care track in the Emory University Internal Medicine Residency Program, and then was ambulatory chief resident for the Emory IM program. She will be starting a geriatric primary care position at Denver Health. We're so excited about that for her, and is passionate about health equity, her daughter Eloise, and building with Lego. So really excited to hear your talk this morning. Thanks.
Thank you so much. All right, so nice to see all your faces bright and early. So I'm going to be talking today about health disparities among older adults, specifically in dementia. And I include beyond because the talk's going to center on dementia, but there's a lot of risk factors that go into dementia risk that are also impacted by disparities. So we're going to get into that a little bit. Oh, I don't have any financial disclosures. I don't know if I have to say that, but I did. All right, so this is the outline of what we're going to go through. So first, we're going to do a little bit of background on race, racism, and medicine. And I think probably everyone is coming from a different level of background, perhaps training or personal experience related to those issues. So I'm just going to try to give like a very brief introduction to some of those concepts. There's much, much, much more to go into around that. But I wanted to make sure to give some level of sort of baseline so that everyone could have the same level of understanding going into talking about dementia. And then the second part, we're going to talk about racial disparities in dementia. So we'll go through incidence, diagnosis, and then management. And there's disparities in all three of those areas related to dementia. And then lastly, thinking about what we can do moving forward to try to mitigate some of those disparities. Okay, so before we start, anytime I talk about health equity or issues around race or racism or identity, I think it's important to talk about where I'm coming from, my own identities, because our own backgrounds and experiences really influence how we show up in this work in this space and how I show up to my patients and in the world and how people treat me. So I'm an almost geriatrician, yay, getting close. Some of my more personal identities, I'm a partner, wife, I'm a mother, that's my daughter with little, those are like ghost things, it was a Halloween thing, in her hair. I'm a sister, very close with my sisters, my family, and a daughter. In terms of more social identity, so I identify as white. My maiden name is Whitesell, so it's like very white. My name now is Garcia, so that's my married name. I included this picture largely to show my husband. This is with his permission. So his last name is Garcia. He's multiracial, and as you can see, he's very white presenting. So he benefits from a lot of sort of white privilege, but also has a complicated identity and background. And just a little disclosure around, I thought very seriously about not taking the last name Garcia when I got married because I didn't want to be deceptive to my patients particularly. But it was important for my husband to maintain his family lineage and not lose that part of him. And I wanted to have the same name as my daughter. So we wanted to keep it that way, but people make all kinds of decisions around that. I will say I think it gives me a little bit of unafforded trust with patients who are Latino because they usually can be like, nah, you're white. um, but they sometimes give me a little bit, I think, more unearned benefit of the doubt because of my last name. I use she, her pronouns. I identify as a cisgender woman. I come from an upper middle SES background. So I grew up in Evergreen, Colorado, predominantly white area. My parents are both like PhD level trained. My dad's a clinical psychologist. My mom is a PhD in child development and works in the School of Public Health. So definitely a lot of privilege from that perspective. I identify as heterosexual and then as able-bodied. I do deal with some mental health things, generalized anxiety, and also OCD. So that impacts how I show up in the world as well. So all of this to say is that, as I sort of alluded to, everyone has different backgrounds and experiences. I'm by no means an expert in the area I'll be talking about. I'm just going to share some of what I've learned over the years and specifically for this presentation, but I also recognize that I have a lot to learn and everyone's going to have different background and perspective that I may not have. So I want to give you a second, just like 30 seconds or so, to reflect on who you are. So you don't need to say anything out loud, just kind of self-reflect on your own identities, maybe in some of those categories that I brought up for myself, and thinking about how that might impact how you show up with your patients or colleagues in the world. So I'll just give you about 30 seconds to kind of think about that. Okay. I recommend taking more than 30 seconds in the course of your life to think about that, but that's all the time we're going to have for today. Okay, so we're going to get into the background on some kind of highlights, I would say, of race, racism, and history of medicine around that. Again, this is very much not all inclusive, but I just wanted to hit on a few key concepts that play into some of the disparities that we'll be talking about. So first of all, a very important concept is that race is a social construct. So it is not a genetic construct. This is from the NIH Human Genome, their like glossary of terms, and it talks about basically that when looking at the genome, there's much more genetic variation within what people self-identify as racial groups compared to differences genetically between groups. And so the important piece here is that race as a concept societally is very true and real and impacts how people experience the world and how culture is developed and how racism impacts people, but it is not a genetic component. And a lot of times medicine and biomedical research makes a false assumption that it is, and therefore can actually end up perpetuating racism or racist ideas around inherent differences between people. That has been shown to lead society to basically categorize people in a way that diminishes some people and raises some people up and treats people differently. So this is a really core concept that is very well established in the literature, but is not really talked about a lot in most medical studies. And so I think it's really important to ground ourselves in that. Okay, so race does impact health through racism. So it's not that race isn't real, it's something that people experience very consistently and impacts how we interact with the world. Um, and we're gonna talk a lot more about what that looks like. Okay, so this is a summary. The US Preventive Services Task Force went through thinking about addressing racism in a systemic way through looking at preventive services recommendations, and they kind of categorize different types of racism into these buckets. So this is one way of looking at different forms of racism. I'm not going to read through all of this, but I'll highlight kind of the ways that they break it down. So structural and systemic racism. So this is basically the way that policies, historically and current day, impact how people are treated and the access to resources that people have. Institutional racism, so this is looking more at like local policies, institutions, how we design our systems, and who they were originally designed for, which oftentimes was white Americans. Cultural racism, this is like in broader society, thinking about language, imagery, symbols throughout society that people are interacting with. Everyday racism, which a lot of times in the literature is similar to what's called microaggression. So this is like daily things that people have to deal with that are perhaps seem small in the moment, but actually have a really large impact. Personally mediated, so this can be both intentional and unintentional racism. Implicit bias falls into this category, which we're all susceptible to based on the society we live in. And then internalized racism, which is where people who don't identify with the dominant racial group may still see the dominant racial group in some ways as superior because of how they have been kind of socialized through society over time. So these are lots of different ways that racism comes to play. And I'm going to go through another example that breaks it just into 3 categories that's older than this. So this was from 2021. This is longstanding. If you've done work around racial equity, you're probably familiar with this. Dr. Jones is a family physician and also was a former president of the American Public Health Association. And she has this levels of racism that she describes through like a metaphor about a gardener. She goes through it much better than I can. So this is a QR code to a video where it's a TED Talk video where she talks about this. But I wanted to highlight sort of how she talks through this to think about it if you want to simplify the buckets a little bit. So the first is institutionalized racism. So she uses this gardener's tale with the idea that there's a gardener who has 2 different flowers that they're going to plant, some pink flowers and some red flowers. And she's looking at 2 different pots of soil she has. And one of them is like dirty dirt and rocky soil that's not very nutrient rich. And one of them has really rich nutrients in the soil. And the gardener says, I like red flowers better, so I'm going to put them in the nutrient-rich soil so that they can prosper. And that is sort of the fundamental concept behind institutionalized racism and how that perpetuates today, which is that people with white identity have historically and currently been given opportunities in the fertile soil, so it were in society, and that allows more sort of growth and access to opportunities. And then over time, the pink flowers maybe don't get those growth and access to opportunities. And then people might say, oh, the pink flowers aren't growing as strong, when actually has nothing to do with the flowers themselves. Personally mediated racism, so she talks about this in terms of the gardener going back and saying, those pink flowers aren't growing very strong, so I'm gonna just pluck them off and have them go to seed. So that's sort of her analogy for interpersonal racism or making assumptions based off of people's race or intentional racism. And then internalized racism, her metaphor for this is that the pink flowers might be looking at the red flowers and saying like, wow, they're really blossoming in that environment. So the bee comes along to pollinate. This is supposed to be a bee, I think. The bee comes along to pollinate, and the pink flowers say, I don't actually want to get pollinated by pink flowers. I want to get pollinated by a red flower because the red flowers are better than the pink flowers. So this is a very simplified version, but I think it goes to show sort of the overall concepts in a way that is kind of manageable to understand. So highly recommend checking this out if you haven't. This article is published in 2000, so it's been around a minute. Okay, so going through a few key highlights of history of racism in medicine because it frames how we interact with our patients and our patients perceive us. There's a lot more than this. I'm just going to hit a few very unfortunate highlights. So first of all, very extensive history of experimentation on Black people during and after slavery. One example, Dr. Sims, who is seen as like the father of modern gynecology, did most of his work through forcing Black enslaved women to undergo surgery without anesthesia as part of gynecologic experimentation. There was also a US Public Health Service STD inoculation study that was done with folks in Guatemala, and they were studying penicillin as prophylaxis against syphilis, gonorrhea, chancroid. So they actually inoculated folks with STIs to see if penicillin worked. So specifically, they did this with sex workers, people in prison, children in orphanages, and people with mental illness. So very targeted, vulnerable populations. And obviously, that has a pretty significant legacy in terms of why there might be mistrust of our institutions. That's US Public Health Service, very like government sanctioned. Tuskegee syphilis study, I think probably most of y'all have heard about, but I just wanted to show how long this went on and until when. So in 1932, the Public Health Service wanted to follow the natural course of syphilis in Black men. They told participants they were receiving treatment, but they did not actually receive treatment. This lasted for 40 years, even after penicillin was identified as an effective cure for syphilis in 1947. After that, almost 20 years after, the CDC, the AMA, and the NMA all supported continuing the study. And then in 1972, finally after ethical review, it was ended. So 40 years, 1972, like many people in this room, all of our patients were alive at that time. So this is very recent history. And at one point afterwards, there was a class action lawsuit that resulted in $10 million settlement for and lifetime care for study participants, which to me is not that much. And then forced sterilization of American Indian and Native women. So this was also in the 1970s, 1973 to 1976. This was mediated through the Indian Health Service by the federal government, where about 3,400 women were sterilized without their permission or knowledge during other procedures. That's a very part of a much longer history of abuse of American Indian women. So those are just a few highlights, hard to hear, but very real. And I think have a huge impact on trust, which I'll get into a little bit more. Okay, so now with a little bit of background broadly about racism and the history in medicine, we'll talk about racial disparities in dementia specifically. We're gonna go through incidence, diagnosis, and then management, and disparities in each of those areas. Okay, so incidence disparities. So this is very well documented. This was my favorite figure I could find to kind of demonstrate the cumulative incidence of dementia by racial and ethnic group. So this gray line is Hispanic. A lot of these studies, by the way, use Hispanic. Some people may identify as Latino, but they categorized as Hispanic, just so you know. This light blue is Black, orange is Asian, this darker blue is American Indian, Alaska Native, and this kind of gray color is white. So you can see that the incidence is lower in white patients compared to all the other racial and ethnic groups that have been studied. And overall, this amounts to, on average, about like 1.5 to 2 times higher risk among non-white racial groups compared with white racial groups. So why? So we're going to talk a little bit about how this has come to be and why there's a higher incidence. So thinking first about potentially modifiable risk factors, and then we'll go into disparities in those. So as many of you probably know, the Lancet Commission puts out like reports about dementia regularly. In 2024, they put out this report looking at these potentially modifiable risk factors and what associated percentages of cases of dementia could be potentially prevented in each of these areas. So in early life, it's lower educational levels, 5% of cases. Midlife has a lot. Hearing loss and high LDL, that one was actually added in 2024, are the highest risk factors. And then depression, TBI, physical inactivity, diabetes, smoking, hypertension, obesity, and excessive alcohol. And then in later life, social isolation, which as we know impacts so many things for our patients. Air pollution is a pretty significant factor, almost half of the impact of hearing loss. And then visual loss was also added in 2024 with additional data. So just these are the underlying risk factors. So looking at that, there's a few different studies that have looked at some of those factors and then the distribution of prevalence of those different risk factors among different racial groups. And so a lot of them are more prevalent in people of color. And so that's sort of the mediating factor, or most significant mediating factor, is the risk factors being more prevalent. So some of these you can see, and I'll show another graph too, like lower educational levels, hypertension, obesity, depression, social isolation, diabetes, and then air pollution are some that have differentiating levels. This is from a different study looking at similar things. So here the orange bars is American Indian Alaska Native patients. Dark blue is Asian patients. This tan color is Black patients. Light blue is Hispanic patients, and the light gray is white patients. So in most of these different categories, looking at different risk factors, or it's kind of small up there, but there is higher prevalence of those risk factors. So makes sense, higher prevalence of the risk factor leading to higher prevalence of dementia. So why is there higher prevalence of the risk factors? So ultimately what this comes down to is social determinants of health and racism at those different levels that we have talked through. So this is a diagram from the study that sort of conceptualized the impact of structural racism on dementia through mediated by these 5 different components. So the first is educational access and quality. So things like school funding, coming from property taxes. So because of redlining, where people of some racial groups were denied mortgages or had to meet different qualifications for mortgages, led to a lot of segregation in housing, and so leading to differential access to high quality schools. Economic stability, so access to generational wealth, access to economic opportunities. Social and community context, discrimination related to discrimination is related to being socially isolated, and also correlated with cognitive health changes such as memory and perceptual speed, and also depression. So if you're experiencing a lot of discrimination, you're probably going to have more of those outcomes, and especially that isolation piece that we saw was like 5% of risk. Neighborhood and built environment, so significant zip code disparities. This includes things around access to safe outdoor spaces for exercise. So we're like, you should go walk to help your osteoporosis, but like you don't have a park or a sidewalk and you can't access that. That's not really going to work very well. Air pollution is a really significant one. That one was 3% of cases of dementia, and I'll get into that in a moment a little more. Access to grocery stores with healthy foods, access to community centers, adult day centers, all of that is variable based off of neighborhood, which again, because of history of redlining, is largely racially concentrated. And then healthcare access and quality. As a public health person, I have to say that healthcare only accounts for 20% of health outcomes, and 80% is accounted for by the rest of society and public health. But healthcare access still does have a pretty significant impact. So access to chronic disease management. So can you control your blood pressure in midlife? Can you get access to control diabetes in midlife, and therefore reduce your risk of dementia in the future? And then delayed diagnosis, which I'm going to go into in a lot more depth. I want to highlight a couple things about Colorado specifically in case you're like, this doesn't apply here. So just looking at some of those social determinants of health here. This is from a really cool map it's an interactive mapping tool through the Colorado Department of Public Health and Environment. And you can kind of layer on these different things. So this is areas, this is sort of the Denver metro area for orientation. This is Aurora, Denver, Commerce City, down here is Lone Tree. So I layered on people of color population above 40%. So this is just our baseline, what we're looking at. So all the gray areas do not meet that criteria. All the blue areas do. And then if we layer on low income population above 40%, so that maps quite unfortunately well when you overlay. So it's not 100%, And it obviously should not be, but I just want to point out that there is definitely disparity in our areas. And then this is a Colorado EnviroScreen percentile. So this is where I think it's like 35 different kind of data points that the public health department uses to create this environmental risk score. So it's like air pollution, water pollution, things like that, sidewalk access, park access, grocery store access that I was talking about. And so higher scores are worse. So a score above 80 maps to kind of worse environmental conditions. And so you can see that that also overlays. This is population level data, but I think it speaks quite a bit to those trends. And again, that's because of historically and current day policies that perpetuate those inequities. Another thing I'll just point out specifically, if you're thinking about Denver neighborhoods, so like Commerce City, there's a ton of air pollution. My husband's grandma lives in Commerce City, and like you can't drink the water there. We have to bring bottled water because it's unsafe. So like definitely toxin exposures. Also Elyria, Swansea, and Globeville neighborhoods, predominantly people of color. I-70 and I-25 were intentionally built through those areas because people didn't have enough like power within political systems to fight against it. And now they're disproportionately impacted by air pollution. So this is very real in our communities. Okay, so in addition to those social determinants of health, thinking about the physical impact of experiences of racism is also a significant influencer of why these outcomes exist. So there was just a recent meta-analysis looking at racial discrimination experiences being associated with elevated acute cortisol levels, which translates to, and there's been other studies looking at overall allostatic load from chronic fight or flight, having to kind of fend off all those different levels of racism. So elevated inflammatory markers, fibrinogen, IL-6, and CRP have all been found, increased daily cortisol variation, and those have correlated to elevated blood pressures, increased heart rates, and elevated A1C. So again, maps to increased hypertension, diabetes as risk factors. And then epigenetic changes as a result of allostatic load and adjustment to that chronic environment of experiencing discrimination occur, and those can actually be passed on to children. So in addition to other forms of generational continuance of disparities, that is a very tangible biological way that that is passed on. So this is all very similar in terms of other health disparities that we see. So a lot of it ties in similarly to dementia. Okay, so we're going to talk about diagnosis disparities in dementia. So there's a significant delay in diagnosis that's longer for people who are non-Hispanic, Black, Hispanic, and Asian compared with non-Hispanic white patients. So that naturally leads to more advanced disease at the time of diagnosis. And this has persisted across different studies after adjusting for functional status, healthcare utilization, age, sex, comorbidity burden, neighborhood disadvantage, and virality. So still persists this delayed diagnosis. And you could argue, and I think some people do, that delayed diagnosis might not have a huge impact on people, but I'm going to talk a little bit about why it might, and especially as we have advances in dementia treatment. So like you could also say that anti-amyloid therapies are not the best thing in the world, but access to that is for MCI and mild dementia, Alzheimer's specifically, but those things are impacted by delayed diagnosis. If you're not getting a diagnosis till moderate or late stage dementia, then you aren't going to get access to those treatments. And I expect there to be hopefully developments in the future that also you would need access to at an earlier stage. I'll go into a little bit more about some other reasons. This is just looking into a little bit of the numbers around the delay. So this study in 2022 found that Black patients were significantly less likely to get timely diagnosis of both dementia and MCI. The odds ratio for dementia diagnosis was 0.61. And for timely MCI diagnosis was 0.4. And then this other study in 2021 looked at CMS claims data, and they found about a 44-month delay for Hispanic patients, 35-month delay for non-Hispanic Black patients, compared to about a 31-month for non-Hispanic white patients. So I wanted to share this. This is a study that was done with caregivers of minoritized patients living with dementia and looking at their perspectives on the impact of having a delayed diagnosis. So I'll just read a couple of these. This was from a spouse who identified as Hispanic. Well, it was, I would say, good, referring to eventually getting the diagnosis. Not good, but it was something that we at least finally found out what it was, because before we were not sure what the problem was. Now we know how we have to deal with it. Another one from a child caregiver who identified as African American. We could have done a lot of things to make memories while he had the capacity to make memories. So thinking about planning ahead and knowing what might come and how people might prioritize their care and how they interact with society and the world and their family, knowing that things will change in the future. And then this last one, also from a child. Yeah, I mean, I probably would have did more research or would have contacted the county office of aging, which I did later when it was diagnosed, to find out which services were available or what training or what seminars or things that I could go to so I can better understand what's happening to her, so I can better take care of her. So access to resources, planning ahead, and knowing what the problem is and not just thinking that this is normal aging is all really important in addition to the medical treatments. Okay, so management disparities. In addition to diagnosis and incidence, also I just have to say with delayed diagnosis, like the incidence is probably higher, right, than for people of color, even than the disparities that are already shown. So management, minoritized patients are less likely than white patients to receive timely and accurate diagnosis, which I talked about, be prescribed anti-dementia medications, which I'll get into, and use hospice care. Minoritized patients are more likely to be hospitalized and receive more aggressive end-of-life care. So medication prescribing, this is from a 2022 study. And after controlling for demographics and clinical characteristics, they found that initiation of treatment, and so this was a prospective cohort study, so started with people who didn't have diagnoses medication, that Black and African American participants were 9.9% less likely to get a new prescription for acetylcholinesterase inhibitors, and that number was 7.4% for Hispanic patients. And then for memantine, it was 8.2% less likely for Black African American participants and 8.5% less likely for Hispanic participants compared with white participants. So pretty consistently, and all those are significant p-values, pretty consistently lower rates of initiating treatment. This is looking at some other treatment outcomes in addition to medication prescribing. This was a study in North and South Carolina looking at Medicare claims data. They looked at both people with dementia and Parkinson's disease, and they adjusted for a lot of different covariates. And they found that Black beneficiaries compared to white beneficiaries had 4% higher all-cause hospitalizations, 8% more days in skilled nursing facilities, 14% fewer days in hospice facilities, 38% less likely to receive PTOT, which to me is like, that's a big deal. You should probably address that. 8% less likely to receive dementia medications, which is consistent in this study and the other that I just showed you, around 8% difference. And then 19% less likely to receive Parkinson's medicines. So definitely differences in how we are treating people, not just their actual diagnoses. So again, talking about contributions from systemic and interpersonal racism, this is percentage of patients who reported when seeking healthcare for dementia specifically that they had experienced discrimination, broken down by racial groups. So 50% of Black Americans, 42% of Native Americans, 34% of Asian Americans, 33% of Hispanic Americans, and then 9 compared to 9% of white Americans. 42% of Black American caregivers of people living with dementia reported feeling that providers or staff did not listen to what they were saying because of their race, color, or ethnicity. So this is something that's like, we have some direct power over, right? So building trust and listening to our patients is extremely important. I'm also going to show you that this data I actually originally pulled for a different talk on dementia I gave a couple years ago in 2024 from the CDC. And I went to look and see if it was updated, and it said this. So just be aware that you might not find a lot of this information. I decided to leave it in because it was there 2 years ago. But a lot of it is now being sort of blocked from access to people. So I just wanted to make that clear. Okay, so just wanted to highlight again, mistrust, or rather, I like to think of it as our lack of trustworthiness. So it's not the patient's fault that they're mistrustful. It's our fault as an institution of medicine that we have not earned trust appropriately. And so the historical abuses, ongoing racism that I talked about with some of those historical examples has been shown to reduce trust of the medical system by minoritized patients. Makes sense. Um, and then thinking about that hospice and end of life care, I was looking into a little bit about like why there might be that differential in people of color using less hospice services. And there definitely needs to be more research into understanding this with community and I would say more qualitative studies would be helpful. But from what has been found, definitely mistrust can impact perceptions of hospice care as the doctor or provider is giving up on the patient. And like, you don't care about my family member, you want to give up on them because of being rooted in that lack of trustworthiness that we have. So assuming that we don't have the patient's best intentions in mind can definitely be one component. There's also some indication that there can be differing like cultural understandings and differing understandings around like spirituality and how that relates to whether or not someone would be okay with being DNR and things like that. So that's also a contributing factor. Okay, so thinking about what we can do, because I've told you a lot of depressing information. I pulled a few things from literature and things that are currently being done, and then I sort of brainstormed a couple things on my own and would love to hear your all's thoughts. So this is you won't be able to read this, but this is a big sort of diagram that this was published in 2022 in the American Journal of Geriatric Psychiatry, and they sort of broke down, I think it's a nice breakdown of the impacts of so this is Alzheimer's disease and related dementia is what it's talking about. So the impacts of racism and discrimination in Alzheimer's and dementia, breaks it down into structural racism, like we've been talking about, institutionalized social determinants of health, and then systems level barriers, and then intermediate determinants. So this is mediated by us in terms of implicit biases, experiences of discrimination that people have, and then the way that that impacts risk. So that's sort of the framework they used, and then they layered on these potential interventions. So thinking about, I'll go into the next slide, I sort of wrote them out larger. So thinking about on the policy level, they talk about community investment. So this is really getting at those social determinants, thinking about access to parks and sidewalks and transportation and healthy food and funding for schools, all of those different pieces. Changes in reimbursement models. So this gets a little bit into, I don't have time to go too much into language, but into patients who might have discordant language with the provider, having like longer visits be allowed or reimbursed differently to accommodate for that so that people can get the same quality of care. Systems level interventions, so enhanced care coordination across systems and improved health information exchange. They talked about public health integration and partnership, which I'm always a fan of. And then on the interpersonal level, patient-centered care, which I know we always try to do, patient engagement and empowerment. So this gets more into like community education and engagement, individual care management for patients, and then better training for healthcare workers on things like bias and racism. I put LOL is not part of this. Bold PHCOE on EDD is the name of this, which just made me laugh. So building our largest dementia infrastructure public health center of excellence on early detection of dementia. So this is a center at NYU that is CDC funded. And this is their mission. And I think they have some good resources specifically focused on enhancing early detection and diagnosis of dementia. There in this article that's referenced down here, they talk about focusing on equitable detection. Again, on their website, it does not mention the word equity, but that's sort of how they were founded. This is a QR code to their website where they have some toolkits that are broken down into like community-based organization toolkits, public health department toolkits, and then health systems toolkits for ways to think about enhancing early detection in our patients. So for us, health systems is most relevant. Some of you may be involved in public health work or community-based work as well. I also really like Us Against Alzheimer's has a Center for Brain Health Equity. They also have some really helpful toolkits. They recently published, it's like a communication guide for communicating information with different populations about dementia and understanding dementia and memory. So that's what that links to. I think that is a potentially good resource that we could utilize as well. Helpful for systems. I recommend just looking through it as well on an individual level to think about how you interact with patients too. This is a little bit about the community education empowerment side of things in terms of increasing education understanding about dementia. There has been some studies showing that some communities of color might see memory changes more as like normal aging as opposed to dementia or cognitive impairment associated. And so these studies sort of targeted that. And so they looked at 25 different studies. They ranged from like YouTube videos to faith-based community educational sessions. And they found that a lot of these did show improvements, but it was like on pre-post surveys kind of a thing from these educational interventions. And so really their main sort of conclusion from this is that we need more like high quality, longer follow-up control group type studies to see if there's larger scale educational interventions. What I will say about that is that sometimes large scale is not the best, meaning like you often have to tailor something to a specific community and not make assumptions about or generalizations about a population. So like each local community is probably going to have different experiences and potentially values and like cultural practices. And so saying like, we're going to give this to all patients who identify as Black is probably not going to be the most effective thing to do. So that's my word of caution about their conclusion. Okay, these are just some ideas that I had. We should listen to our patients and particularly be sure to do that very intentionally when working with patients of color. So recognizing this gets back to reflecting on our own identities, thinking about how that's interacting with patients and how patients might perceive us and being particularly cognizant of that when maybe going into a room with someone who has a different racial identity than you do or other identities. Reflecting on our own biases and assumptions, seeking out equity implicit bias trainings. I'm guessing most of you have had some exposure to the implicit association test, although I don't know. So this is like at Harvard, they do, you can just go online and like do these, it's like a reaction time test looking at your sort of underlying associations. It goes into a lot of different dimensions of identity. That can be a good starting place just to think about the things that you might not necessarily realize are implicit biases. And I think people sometimes feel bad about that because we don't want to have intentional biases or discrimination, but we all have some level of implicit biases, and I think that test can sometimes just help prompt us to think about that. There are also sometimes available like equity implicit bias trainings on campus, so being on the lookout for that. Things that I'm like thinking about for my own patients, like am I underprescribing for some of my patients? Are there patients that I should be offering medication to that I haven't? And am I doing that in a differential way based off of their identity? And then am I underdiagnosing patients and thinking about how I should specifically pay attention to diagnosis and be a little bit more mindful of that in my patients of color. And then remembering the history of medicine when we interact with patients of color, particularly who may not want to be compliant. This is like a common word used in medical documentation that is harmful to patients because it often perpetuates bias against them as being non-compliant. And so thinking about why does someone not want to do what I'm recommending? And might it be that they're not going to say out loud, I don't trust you, but like, or they might, but more commonly probably not. But thinking about that could be contributing, being very cautious and thoughtful about your wording and documentation. Which I know is hard, and I'm curious to see how AI documentation impacts that. But I think being mindful of that is really important. And then also thinking about specifically with end of life, like what I might perceive as right or what I would do might be different than what someone else might do. And that's okay. I don't need to like force them to think about it the way that I do, but I do need to make sure to provide education so they can make an informed decision. And then this is sort of my like life motto. So making decisions with trustworthiness and equity in mind. So thinking about as you move through your day, whether it's a patient interaction or a research study you're working on, or a systems level decision or a meeting you're in, just like, is this aligned with being a trustworthy provider and a trustworthy medical system? And is it aligned with equity? So I like to just think of it that way. This is not evidence-based. This is just things that I have brainstormed and tried to work on myself that I can continue to work on. So that is that. So that brings me to the end. I would love to get any ideas that you all have in addition to my list or questions.
Talk and opportunity for us all to reflect and also brainstorm. I was thinking about the guide model, which is only available to individuals who have Medicare fee-for-service. And we also know that Medicare Advantage is could be, seen as a way of offering things to some people, but not to others, sort of a structural racism issue. Comments, questions?
Thanks so much, Mackenzie. Appreciate your wonderful talk. And the fact that your blouse matches your slides is really quite something. I don't know if you planned that, but
Please excuse my
okay.
soul.
Well, it was really something. So I was just thinking about the various, monoclonal antibodies and things, and I realize they're not great treatments, but is there literature about what's happening there with regard to disparities in offering these treatments?
That's a great question. I didn't find anything specifically about monoclonal antibody disparities. I think possibly because it's like so new that there hasn't been as much research on it, or I might have just not been able to find it. Most of what I found was about like the memantine and acetylcholinesterase inhibitors. My guess, I would be shocked if there were not disparities because of the difference in delay in diagnosis. So access just based off of the timeline of diagnosis, but definitely something I'll be looking out for. And if anyone knows of any existing data, that would be great. But yeah.
Yeah, and then also not just the access part, but all the side effects, and are those viewed in a different way between different ethnicities?
Yeah.
So anyway, thank you.
Really great talk, Mackenzie. My name's Mackenzie too, so great talk.
Love it. Hello, Mackenzie.
First off, that video is really good. So anyone who hasn't watched the video, it was life-changing for me, actually. And then my question, I guess, that I have is I struggle with earlier detection because I think we need better biomarkers for earlier detection, but also people aren't getting help early enough, right? So then it's hard to track how they're declining. So I guess, do you have any ideas on that? And then my second question is the genetic differences because I know Black people have a higher ApoE4, which is a great risk for dementia, right? So can you touch on how we can maybe better educate around genetic differences as well?
Yeah.
And how that interacts with their environment, exposure, and everything, and can progressive speed up their decline, I guess is what I was trying to say.
Yeah. So thank you for those. I think in terms of early detection, I think biomarkers is an important area that's like evolving and definitely can provide additional insight. I think that one concern or issue with that potentially is like access financially in terms of coverage for using biomarkers. And I would anticipate that there would be some level of gap in access to that. So biomarkers may enhance early detection for white patients more than early detection for patients of color based off of some of the sort of discrepancies that we see. But I think if done intentionally and thinking about how that could potentially widen a disparity, I think that is an important thing to think about. And then in terms of ApoE4, yeah, I didn't include much about that in here. And I don't have numbers about like how much that is the case. I think part of it is it would be great if genetic studies looked more at like lineage and heritage, since like Black is not like really a genetically defined group, even though that's how it has been written in the literature frequently. So thinking about like, what is the actual, looking into the actual heritage of that. So we could ask people more about their like lineage and background to try to better elucidate that, and then maybe educate those patients more about potentially increased risk.
Thanks, Mackenzie. That was really good. One thing I really struggle with clinically is diagnosing like mild cognitive impairment or early dementia in minority people, because a lot of times I don't know if it's education, I don't know if something's lost in translation. And I worried about labeling dementia in their chart, because then we kind of go down that other route where people are treating them like they can't make decisions and taking away their rights. So I don't know what, and a lot of them kind of like refuse to take the test, or again, it's like a test anxiety. Are there any studies on how, like their perception of how dementia is diagnosed, or any balance to that?
Yeah, that's a great question. I did try to look into any studies around that. I couldn't find any specifically, and I wish that there was more. I did find some things about like different screening tools are like better validated in some different populations. So like, I couldn't find a study on this, but it just makes a lot of sense to me that like the slums, when it's talking about like Jill and Jack and the stockbroker, you're like, okay, this is like not very like relatable probably, and might impact someone's score on that test. So those types of things. I think there was one study I looked at that said like many mental status might not be like as valid in some certain populations, but it didn't really go into a lot of depth about why. So, and I couldn't find any that looked at what might be a better alternative. So it's something that I think is an area that needs more research and looking into. And I would love to get more data, more of those like qualitative studies. I'm a big qualitative study fan, to get perspective from people about their perceptions of those tests. Totally agree. It's a big challenge.
Thank you for a thought-provoking talk. I was curious to get your thoughts on the intersection of racism, social determinants of health, and dementia risk. If you, in your opinion, if you could move the needle on one of the social determinants of health more than another to have the greatest impact on dementia risk, just curious in your opinion, which of those social determinants would that be?
That's a great question. If I were going to impact dementia risk in 70 years, it would be education, because that was 5% of cases, so close to hearing loss and LDL levels. And hearing loss and LDL might be a little bit harder to, I mean, no, education is going to be harder. But in 70 years from now, that's the like early life intervention. And I think that that would have a huge impact on dementia, but also a ton of other risk factors. In later life, one of the ones that is like persistently interesting to me is the air pollution piece, that I think is like 3%. And so like, can we build our roads more equitably? Like we can't, those are all massive things that are not going to be like a simple fix, but in a perfect world, I think that is an interesting one, and one that we like never really talk about in terms of dementia risk. It's not something that comes up clinically, at least in my experience, that has been a routine thing. So those are a couple.
Okay, thanks.
Other comments, questions? Kenny?
Thanks for the presentation. I really liked how it was laid out. I was just curious to think through when you were looking at these papers that were discussing, delays in diagnosis or problems with management. I was curious to know what you thought about the discussion of these papers, because the discussion is where you're really supposed to try and plug into the broader debate and context around issues. Did they all sort of just conclude like, well, we just need to make everything more equitable? Or did you feel like they were doing a good job of like highlighting some of the challenges that you also brought up? Like, what does it mean for a race or culture to self-determine what they want from their sort of diagnosis, management, how that's defined? And I think that brings up some of the points that Mandy brought up as well, that like the challenge with dementia is that there's a lot of stigma attached to it, that as like a poll, it's like, do you want a dementia diagnosis? Like even that is unclear. So it's like, do we want like that you have an equity issue, and then it's like, is the outcome something that we want to drive to? So what did you see work in that vein, where groups had a chance to or assembled community groups had a chance to say for themselves what is it that they want? And can you share if you found that?
That is a really good question. I would say mostly not, in terms of discussions. From most of the studies I looked at were like, we need to address social determinants of health, we need to address equity issues, but mostly there is not a lot of those like community-based studies that looked at like true perceptions. There was a little bit where people maybe in their discussion sort of alluded to that, but it would be like a couple sentences, not necessarily the biggest focus. And so I personally think that's a huge area for ongoing like research and understanding, is really getting like community perspectives. Like you're saying, like, do people want to know? Do they understand the benefits potentially of knowing versus like, are there versus their perceptions of the risks of knowing? And then how would they want to be screened, treated, addressed? I will say the one that kind of got at that a little bit was the one that I shared some quotes from, that was like specifically with minoritized patient caregivers. And that one, like most of the caregivers said they wanted an earlier diagnosis. That was mostly with Black and Latino patients. And so that was the one that was like most community driven. And they talked about that in their discussion, but most of them otherwise didn't really get much into that being like a core focus in the future. So I'm glad you brought that up, because I agree that that is probably the most significant promising direction we could take that.
If you could change something in our current healthcare system, like the hospital at large or in seniors clinic in the next year, like one or two things to like improve the way that we're delivering care in a more equitable way, what would you change?
That's a really good question. I might have to mull on it more, but I would say in a perfect world, I would love there to be different appointment times based off of language concordance. That's only specifically a subset of patients. That's not going to address all like racial disparities, but I don't think that's feasibility of that is different than like my hopes. I would also say, actually, even I think having more time, even maybe not necessarily in language discordant, but like we have a lot of time already. So this is less of a seniors clinic problem and more in general, but like having more time, I have definitely found helps build more trust and like gives you the time to listen to people. And so that's more of like a systems wide thing, not seniors clinic, but like maybe into other like primary care practices where like older adults might be able to get more time, even if they're not seen at our clinic, because that like longitudinal trust building and like trustworthiness developing comes a lot from time, and like taking the time to listen to maybe that individual about like, do they want to be screened for dementia? Like what are their end of life wishes? So it's not necessarily within seniors clinic power, but that would be an ideal, like a broader across the system, since we don't see all of the older adult patients.
It's also reflecting the fact that both seniors clinic and the VA, like once you make it into clinic, the interdisciplinary team is open to patients regardless of insurance status, is one of the things I was thinking about. Whereas, you know, once you're outside of our clinic, it's prior auth this or not covered by that, you know, trying to find a home health agency, but thinking about the resources we have as a team and just continuing to coordinate well, and hopefully the clinic can be a trustworthy place. Often, you know, one relationship is trustworthy, but how can we have like a trustworthiness as a whole clinic?
That's such a good point. Thank you.
Fabulous. Have a great Thursday, everyone.